Hi, everybody. This is Vamshi Rao. I am a pediatric neuromuscular neurologist at Ann and Robert H. Lurie Children's Hospital in Chicago. And I'm really happy to be here with Dr. Noritz. And as we talk about screening for assessing and diagnosing DMD, Dr. Noritz, please go ahead and introduce yourself.
Sure, thanks. I'm Gary Noritz. I'm an internal medicine and pediatric physician at Nationwide Children's Hospital and The Ohio State University. And I work in a clinic that takes care of kids and adults with disabilities.
Dr. Noritz, let's start with how one would screen DMD in primary care.
Yeah, sure. And this is a great topic for pediatricians and family doctors and anybody else who takes care of children, in that we don't know what, if any, behavioral or developmental problems they're going to have when they walk in the door. And so we have a process of developmental screening, and the American Academy of Pediatrics recommends that we do this using a validated screening instrument at 9, 18, and 30 months of age. At those visits, we talk to the family about their developmental progress, do a neurologic exam, and we may find a problem that might alert us to a diagnosis such as Duchenne muscular dystrophy. Especially at the 30-month exam, signs of Duchenne muscular dystrophy might be evident, like low tone, difficulty walking, difficulty running, and difficulty climbing stairs. And the things we might see on the exam at a 30-month-old visit is a child that can walk, but might have to get off the floor using the Gower sign. And we might see that their calves are really quite large, and we call that calf pseudohypertrophy. And all five of those things are things that you might see in a child with Duchenne muscular dystrophy. And so if a pediatrician sees that a child has low tone, has some motor delay, maybe has a Gower sign or the calf pseudohypertrophy, and thinks, this might be a muscle disease such as Duchenne muscular dystrophy, there's a couple of pretty easy things that we recommend that the pediatrician do. Number one is to start a diagnostic workup, which would be to send a creatine kinase, or a CK, blood test from the child, and also a TSH, was the thyroid-stimulating hormone. And both of those things might present pretty early in childhood. And if either of those are abnormal, then we might go down a road of saying, this could be something like Duchenne muscular dystrophy. At the same time that we're sending that test, we can be referring the child to early intervention and to physical therapy, and also at the same time referring to a specialist who's able to make a distinct diagnosis such as Duchenne, such as yourself in neurology, or a geneticist, or a developmental pediatrician.
Thank you, Dr. Noritz.
So the next question for me then is, if I do have a blood test come back and the creatine kinase is really quite high, that's going to set off an alarm bell for me that says, this could be muscular dystrophy, and I'm going to get on the horn to my friendly local neurologist or neuromuscular specialist and say, hey, I've got this kid, I'm worried about Duchenne. I'm going to send him over to you. What are you going to do once you get that referral?
Yeah, that's a great question. I think following from a high CK level that basically makes you suspect a muscular dystrophy such as Duchenne, the next test that I would really think about is a genetic test. In today's day and age, genetic test for a dystrophinopathy that would detect a mutation in the dystrophin gene that could either diagnose a condition such as DMD or Becker muscular dystrophy, depending on where the mutation is and what kind of mutation is, will be the next step. The important thing about a genetic test is it's a blood test. It could be a swab, so it's relatively non-invasive in that sense. And a genetic test also has an additional advantage where we can also test the family members to see if they're carriers for a dystrophin mutation. As I mentioned, in this day and age, what I meant to go next to is we are doing less and less of muscle biopsy because muscle biopsy obviously is more invasive than a genetic test. But muscle biopsy does have a place sometimes in the sense that if there is any uh, doubt or any sort of gray area in terms of the genetic tests not being confirmatory, we can do a muscle biopsy and stain it with a dystrophin stain to look for the presence or absence of dystrophin protein. It can also, depending on whether there is a complete absence to some presence of dystrophin that correlates with the clinical scenario, help distinguish between Duchenne muscular dystrophy and a Becker muscular dystrophy.
One thing I wanted to mention is that here in Ohio, we've just started doing newborn screening for muscular dystrophy using creatine kinase in the newborn screening blood spot. And so that will probably expand to other states as time goes on. But I would urge everybody to not rely on that because, while it is a very good test, there's still, it only just started, and many of the kids that we're going to be seeing over the next several years will have been born after that got started. And so if there is any concern, a CK is an exceedingly cheap test to send, and I would certainly recommend that you just go ahead and do it, even if you think that they had a newborn screen that was normal.
That's a great point, Dr. North.